Okay. All right. Okay, I think we're all good to go. Tēnā koutou katoa, and welcome to our first Bioethics Centre seminar for the year. It's a real pleasure to welcome our speaker for today, Dr. Kata Chillag from Davidson College. Kata is the inaugural chair of the Department of Public Health and Professor in Biosciences and Human Health at Davidson. Before that, she spent almost 20 years in the US federal government at the Centers for Disease Control and Prevention, the Office of Global Affairs, Department of Health and Human Services, and the Presidential Commission for the Study of Bioethical Issues, which is where our paths crossed. So in her very exciting and varied career, Kata has worked on polio eradication, HIV/AIDS, influenza, Ebola virus disease, and COVID-19, with particular interest in public health emergencies, the ethical dimensions of complex public health problems, and health workforce stewardship in the US and globally. So Kata, thank you very much for joining us on your Sunday afternoon. We're very grateful to have you. Kata is going to be taking the lead on this presentation. This is a project that she has led and I've just been involved in a sort of bit part. So I'll come in at the end and talk a little bit about some of the ethical dimensions of the project. Just to let everyone know that we're recording the session today, including the Q&A. And we ask for our audience members on Zoom to stay muted during the presentation, and then we'll open everything up for Q&A. Okay, so Kata, the floor is all yours.
Thank you. Let me share my screen.
Great.
Well, it is an absolute delight to cross the international date line to give this presentation at the home institution of now my longtime professional collaborator and friend, Elizabeth. And as she said, I'm going to provide a bit of a background and some highlights from a project we've been working on to frame our discussion of medical migration and brain waste. The title of our project overall is called International Medical Graduates at the Crossroads. And I'll give you a little bit of background about how this project arose, its roots. It arose out of several longstanding professional collaborations. A group of people have been interested in healthcare access, public health, and healthcare access, and the role of immigrants. And there's the collaboration with Elizabeth and also my colleague at NORC at the University of Chicago, Mysoon Frage. And we had been kicking around these ideas for some time, and they were really catalyzed by deep concerns about, in the lead up and election of Donald Trump as president, in relation to threatened immigration policy changes, actual immigration policy changes, and anti-immigrant rhetoric and norm slippage. And so some of those things, the rhetoric and climate, continue to this time, of course. We are really lucky to have an interdisciplinary team, including persons who are on the ground in the main focus of our research, West Virginia at Charleston Area Medical Center, NORC, of course, Otago, and we have a range of expertise in health services, social science, public health, clinical psychology, and of course, bioethics. This project is also personal in various ways. Several of us come from underserved areas where immigrant physicians provide critical healthcare services, and some of us, including myself, have direct familial ties to them in West Virginia, in my case, which I'll talk about more. So what are our project aims? To explore the impacts of immigration policy and climate on IMGs and the institutions that rely on them and train them in the United States in underserved areas in West Virginia in particular. We want to illuminate the experiences of IMGs and those who recruit, supervise them, including cultural and professional challenges facing IMGs, to contextualize the contributions of IMGs in an ethical framework focused on questions of justice and reciprocal obligations, and to identify and develop resources for IMGs, institutions, and policymakers. And there had been a very small amount of scholarship on IMGs. The most of it was in Canada, some in the United States, some in Britain, and a little bit in Australia and New Zealand. And a lot of that work was dated. It was important, but was around quantifying IMGs and their specialties, for example. But a lot of it, as you probably know, was about brain drain. And we wanted to look at the ethical issues in a little bit of a different way, and also use the empirical work that I'll talk about to advance something very important, which is that in the United States, and I think everywhere, the important contributions of IMGs to really essentially ensuring that there's healthcare access in some parts of these countries is underappreciated. And in a context of real anti-immigrant action and rhetoric, we thought it was all the more important to do so. So we're interested in identifying and developing these resources, but their stories are as important to doing so as anything else. So our methods included sort of literature review and policy analysis. The empirical portion of our project focused on qualitative interviews with IMGs in West Virginia at all career stages. So importantly, yes, we're looking at the different impacts at different career stages, but we're also looking at different amounts of time in the United States, different amounts of time since their immigration. A variety of healthcare leaders and administrators who work with IMGs and train them in West Virginia institutions, and national, regional, and local organizations which engage with IMGs. And this includes in relation to advocacy, immigration support, sometimes social and professional societies and associations. Of course, we're employing ethical analysis. I won't talk about this much more, but I'll just note that the project was affected largely in negative ways by the COVID-19 pandemic. It certainly required us to revise the empirical component of our study and change the timeline, but it was also affected in positive ways, in that the fact that we continued the interviews in a different forum during the pandemic really allowed us to explore different dimensions of the IMG experience. And there was a bit more attention around the role of IMGs as there was acute and visible healthcare need and gaps during the pandemic. So we finished the data collection phase in late 2020. We have several products from it now, and we're doing ongoing analysis for some others at this point. This project has been supported by the Greenwell Foundation Making a Difference in Real World Bioethics Dilemma program. If you're not familiar with it, it has really been quite a good experience, and it's particularly suited to our work in that it focuses on interdisciplinary bioethics work with applied and policy implications. So turning now to the background for this specific project, let me define what we mean by international medical graduate, or IMG, in the context of this project. So in the US context, an IMG is a person who receives their basic medical degree or qualification from a school outside the US or Canada, not accredited by a US accreditation body. So in this project, we're focusing on two of the three major groups of IMGs in the US: foreign-born persons in the US on non-immigrant visas, and immigrants to the US who hold a medical license, which includes permanent residents, those with a green card, naturalized US citizens, asylees, and refugees. We are not including US-born persons who receive their basic qualifications outside the US or Canada, including those who go to for-profit. There's a bunch of for-profit medical schools in the Caribbean where US-born persons go sometimes for medical school. This is not an unimportant group in relation to underserved areas, but we were really interested in the immigrant experience in particular. One thing that we have learned about a certain set of American-born IMGs through the study is there is an interesting group of persons who are first-generation US citizens, often children of IMGs, who return to their parents' home country, such as India or Pakistan, for their foundational medical education. This is a really interesting move because that medical education is often free or low cost, in contrast to that American medical education, which confers advantages that they and other IMGs might have over US medical graduates. A lot of IMGs in our study really talked about the advantages they perceived disadvantages rather, they perceived in relation to American medical graduates. But in this case, they often said, at least we don't have that massive amount of debt that a lot of American medical graduates have. And recent studies have documented that medical school debt can drive professional choices. That isn't really unexpected, but including intent to practice in underserved areas and in undersubscribed specialties. So according to the most recently publicly available Association of American Medical Colleges data, a little over 24% of the approximately 940,000 active physicians in the United States are IMGs. That's pretty typical in recent times. About a quarter of practicing physicians in the US are IMGs. According to the American Medical Association, the number of practicing IMGs in the US has increased by almost 18% since 2010. The largest percentage of licensed IMGs graduated from a medical school in India with 23%, followed by the Caribbean, 18%, which includes those for-profit schools, Pakistan, 6%, the Philippines and Mexico, 5%. Importantly, and it's really surprising, people don't think about this in the United States at least, but approximately 21 million Americans live in areas where at least half of the physicians are IMGs. And this is particularly the case in rural areas, as well as in urban areas characterized by high rates of poverty. And they really serve groups that often bear the brunt of health disparities. IMGs comprise a substantial portion of those specializing in primary care, broadly conceived, and in specialties important given the burden of disease in underserved areas. And we're not alone in our thoughts that in the absence of major healthcare reform in the United States, the role of IMGs is likely to be even more important with increasing healthcare worker shortage. So this is an interesting analysis in the New England Journal of Medicine, looking at physician density in the United States and modeling out, projecting out to 2030. In about the last 10 years, the physician density in the United States overall is about 27 per 10,000 persons and about 12 per 10,000 persons in rural areas. So you can already see a disparity. From 2000 to 2017, the age distribution of rural physicians changed a great deal. Physicians under 50 years of age decreased by 25%. Over half of physicians in rural areas are over 50 and a quarter over 60. In urban areas, in contrast, the number of physicians younger than 50 grew 12%. So what they modeled out was that in 2030, physician density in the country as a whole is projected to decrease from 12 to 9.4 per 10,000. That's nearly all from retirements of those older than 45 years. In 2030, they project that there will be 1/3 as many physicians practicing in rural areas than in suburban and urban areas. So I have to talk a little bit about the kind of visas that are common for IMGs to come into the country with in order to paint the picture necessary for the discussion. Foreign educated physicians come to the United States under a variety of visa types and represent a range of immigration, residency, and citizenship statuses. However, two visa types dominate, the J1, and that's the one that really dominates, and H1B visas. So here, this table is a little dated, but it's still the same picture now. So here you see citizenship, residency, and visa statuses for physicians in medical residency. And medical residency is the entry point for all IMGs to practice in the United States, though they don't all come on a J1 visa. But again, J1 visas are exchange visitor visas. They're intended for work and study-based activities ranging from a day to a few years. Physicians can be allowed to stay for up to 7 years with an possible extension of 2 more years that can be requested in, quote, extraordinary circumstances. If someone wants to stay in the US once their J1 visa expires, there's a 2-year home residency requirement before those in J1 status can become permanent residents in the United States or get other work or family-based visas. This means that they have to return home. Unless that requirement is waived, and there's a small program or a set of programs, one called the Conrad 30 is most prominent, that allows the J1 return home requirement to be waived if you agree to practice in an underserved area for a certain amount of time. It's often 3 years. The H-1B visa is generally considered to be a path to the green card. It's a non-immigrant visa focusing on occupations that require technical expertise. It is initially valid for 3 years and then can be renewed for another 3. Once it expires, the foreign worker must either leave the US or obtain a different status. And a lot of the times the status they're aspiring to get is permanent residence. But there's a significant backlog for green cards because there's a per country quota. And this is particularly the case for persons from certain countries, most notably India and China. India is the country from which the largest number of IMGs immigrate, as you saw. So this backlog predates the Trump administration. and persists after it, though it was likely more complicated and logistically difficult to navigate under the Trump administration. Now and in the past has been very problematic for IMGs waiting to stay in the US. So this is an illustrative quote about this issue from the study. There's so much of a backlog and everything. Although we have been in this country for 10 years, we're still not permanent residents of the country, and we don't know when we'll become permanent residents of the country. And we as physicians are a very skilled workforce of the country. So why is our process the same as the regular people in the immigration line? Why are we not given preferences and given like a separate route that can be faster? Because we are spending so much time and energy, and the country is benefiting by having us. Regardless of how long they've practiced elsewhere outside the US, all IMGs must complete a series of steps to obtain a full US medical license. I'll talk about those steps through obtaining a residency, as they are most germane to the discussion here. So an important actor in this process is something called the Educational Commission for Foreign Medical Graduates. So they undertake some gatekeeping certification processes, which can cost quite a lot of money, which I'll talk about in a moment. These include making sure that someone actually graduated from medical school and has taken some US examinations that are critical to obtaining a residency. With an ECFMG certification, an IMG is eligible for residency and then must go through the residency application and match process. Now, whether or not they practice for 20 years and are coming to the United States, they still have to do a residency. In truth, most IMGs coming to the US are much closer to their original medical training, but that is also another point of discussion about whether or not that should be the case in a situation where there's great need for these healthcare workers. But in any case, importantly, they must complete a residency in the United States, meeting the requirements of a particular jurisdiction to practice medicine. Moreover, for the most common type of visa, the J1, documentation of acceptance into a residency is generally a prerequisite for immigration. So the residency application process, the match, is a competitive process. Certain specialties, including primary care specialties, all other things being equal, tend to be less competitive, as do programs or specialties perceived to be less prestigious, or in locations viewed to be less desirable, like many rural areas in the United States. So this is one way that rural areas are able to have people come, in that they have, quote, IMG-friendly residencies. Importantly, this process is quite complicated. First of all, it can be quite costly. For example, residency application fees accumulate depending on the number of residencies one applies for, though the per residency cost goes down with increasing numbers. With IMGs adopting a mass application strategy because they are generally less competitive, this can be formidable. The certification process, as I mentioned, can run more than $1,000, including the examination fees, and there may be a variety of other types of costs, including those related to travel, associated with trying to get a residency or residency interviews, although that has changed during COVID. So they're now doing some virtual interviews, reducing at least those kinds of costs. The process of accreditation and immigration is complex, as you can see, and requires extensive research and knowledge acquisition, including, for example, researching these IMG-friendly residencies, which our data suggests occurs in different ways, including through medical school networks, particularly in medical schools that tend to produce a lot of graduates seeking to train or work in the United States. Networks in general are important for many IMGs navigating training and working in the United States, and may be informal or related to organizations for physicians of specific national or ethnic origin. Now, it was more so during the Trump administration, but it's always the case that immigration policies are dynamic, and I would say confusing, and particularly in the Trump administration, but this is a hangover that this could happen anytime there's a presidential administration change. So this perception that this is the case is still impactful. Many recent changes have been rapid and chaotic in their implementation, leaving questions about their implications, implementation, and heightening uncertainty and anxiety as expressed in our study. Always onerous and bureaucratic, immigration procedures from our data suggests they became even more so during the Trump administration, with increased barriers to successfully obtaining information and technical support from immigration agencies. Finally, anti-immigrant climate and rhetoric has further complicated this process, and it can be discouraging for IMGs, potentially resulting in them falling out of the process, never undertaking it in the first place, and discouraging others, including in the networks I mentioned, from considering training or working in the US in the first place. So I'll now talk about the socio-demographic and health context where the research is taking place. This is the Appalachian region of the United States. It follows the Appalachian Mountains, hence the name, from southern New York to northern Mississippi. And it's a big area, as you can see, a lot of diversity in it, but there are some shared aspects of it. And West Virginia is the only state that is fully in Appalachia. The population of Appalachia is in general older and poorer than the United States overall. So this is a production of a small U.S. federal agency called the Appalachian Regional Commission that works in Appalachia and does various things. But the colors on the map represent a measure of economic distress, incorporating a composite of some metrics of unemployment, per capita market income, and poverty rate. The red color indicates that those counties fall in the distress category, the worst 10% of counties in the United States. So here I've pulled out West Virginia, the blue on the map, and you can see a little bit bigger picture of it. West Virginia has the second lowest life expectancy of any US state, is one of the poorest and most underserved states. It faces interrelated economic, environmental, and health crises, including the highest drug overdose mortality in the United States, the highest prevalence of adult obesity, and among the highest prevalence of diagnosed diabetes. So when I talked about certain specialties being very important, specialties dominated by IMGs in these contexts, this includes internal medicine generally and other primary care, but things like endocrinology and the cardiovascular disease expertise. And additionally, West Virginia has been particularly hard hit by the COVID-19 pandemic, including by exacerbating overdose deaths. So we'll note here that West Virginia is like a study in contrast. It is incredibly beautiful. This bridge is the New River Gorge Bridge, which people actually bungee jump off of. It's spectacular. In the background, you'll see something else from the new, like a waterfall, but it's also a place where its natural beauty and extensive natural resources have been extracted by others. And you can see this is mountaintop removal coal mining. Coal is really important to the past and the present, including the health challenges that West Virginia faces. So I'll talk a bit more about that. West Virginia doesn't have a big population. It has a population of about approaching 1.8 million people, and it's consistently declining. That's because, and I can say this because I'm West Virginia, everyone who can get out does get out with skills oftentimes. When I was having a little trouble in graduate school, my father said, it doesn't matter. Your accomplishment is you're out of West Virginia, you know. So only a native can say those things. But importantly, the total 60, it's an old state already, and the total 65 plus population is expected to continue to rise through 2030. And this is not healthy older age with significant economic and health effects. West Virginia is also among the least diverse states in terms of race ethnicity, with about 90% of persons reporting white as the race ethnicity. So that's also important for the dynamics that IMGs find themselves in West Virginia. So we were really interested in West Virginia for other reasons too, because they're relying on this immigrant labor force for their healthcare, but they overwhelmingly supported Donald Trump in our presidential elections. West Virginia has a really interesting political history, which I'm not going to go into here. It wasn't always this right-leaning, and it changed. That was partly the influence of coal mining and unions early. It was more leaned the other way, at least in its voting patterns. But in nationally representative surveys, we've seen the expression of anti-immigrant sentiments, or at least not a full understanding or reporting of the contributions of immigrants, but we also wanted to problematize that picture. I wanted to, as someone from there, of a just sort of superficial stereotype of a certain place. West Virginia has a lot of stereotypes associated with them, which I'm not going to repeat here, but I'm sure there are comparable rural areas in New Zealand where people really essentialize the people from them and look down on them in many ways. Notably, it has the lowest percentage of foreign-born persons, those not born to US citizens in the United States. So again, important to our analyses. This is also from the Appalachian Regional Commission. You can just see that West Virginia has high rates of poverty. It has the lowest median annual income rate of any state in many years. It has enormously high child poverty. It has these enormously high rates of children being raised by their grandparents because of the opioid epidemic. And oftentimes those grandparents are sicker and poorer than their peers. It has extremely high rates of unemployment. and has among the lowest rates, if not the lowest rates, of educational attainment in the United States. Here you see particularly economic distress counties in the central part of the state and the southern coal fields, which is where I am from. And that's, of course, where the extractive industries were concentrated. But importantly, coal mining has always been a really dangerous industry. It's largely collapsed as a way of life, or at least partially. But it was a kind of life earlier where people could have a middle-class existence and stability without much education in a reliable way. So why is West Virginia so poor? You know, some of it is that. Some of it's its topography, its population density, and its declining population, and particularly a hauling out of the middle. It has poor infrastructure and this dependence on coal. So these are so-called diseases of despair mortality rates, ages 15 to 64. And what are these? This is overdose, suicide, and alcoholic liver disease. And you'll see that Appalachia has higher rates than the United States, non-Appalachian United States, and West Virginia has highest rates among Appalachian states. This is really hard to see. I apologize. I'm going to highlight here that this does show the percentage of physicians that are IMGs in West Virginia, which is 28%, which is not the highest, but data are not publicly available or even possibly collected at the county level, at sort of the postcode, zip code data level. And this is really important in places like West Virginia to characterizing the role of IMGs. We have other data. The study informs this and anecdotal evidence, but there are places in West Virginia, particularly the even poorer parts of West Virginia, where essentially it's 100% IMGs. So when we talk about immigration, we talk about push-pull factors, and increasingly in light of the study, I talk about stay-go factors because we think about retention as well. Healthcare worker migration can be conceptualized in a way that migration in general is, in terms of these push-pull factors. So this figure depicts a variety of professional and personal factors that likely contribute to the migration of healthcare workers, and most of these could either be push or pull factors depending on the details. These include health infrastructure, which can be a push factor. Healthcare workers can maybe drawn to practice in a health system with different attributes. We heard from our study in high technology medicine, they really wanted to do that. But it can also include how health systems are organized, financed, their philosophical orientation. They may be pushed or pulled away by what might be categorized as career factors, such as training opportunities, remuneration, patient load, or opportunities for advancement. At times, health workers may be actively recruited to immigrate or work elsewhere. I will say I saw something, and I've told Elizabeth I've looked for it over and over again. I'm sure it wasn't a hallucination, but at the sort of the peak of some of the anti-immigration stuff starting in the United States, I did see something saying, come to New Zealand or Australia, we'll welcome you. And I've looked and haven't found that. They may be drawn or pushed away by personal, social, cultural, political, religious, or economic ties and conditions. And finally, their choices about if and where to go and stay may be influenced by immigration policy, climate, and logistical difficulty. So again, thinking about these push-pull factors, what motivates IMGs to practice medicine in the US or West Virginia? So I've already talked about a major one. It's that they can get a residency there. They can get a job there. I've talked about another, they might have the chance to practice more advanced high-tech medicine than in home countries. They might be able to get a residency elsewhere, but they don't have those waiver programs where they can stay and advance to a different immigration status, at least ostensibly more easily. Sometimes they report alignment in values with rural places, family orientation, sort of a slower pace of life, things like that. They often report generally positive interactions with patients, viewed as kind and accustomed to foreign doctors in West Virginia, which is interesting. A lot of times the people in our study said, it wasn't so much that we were foreign, it's that we were not from West Virginia, a general wariness of outsiders. And they also have reported things like they contribute to philanthropic efforts, medical or otherwise, in their home countries. They may have relationships already, marriage to someone there, family there as well. And there are other kinds of economic benefits. Sometimes there are better salaries and sometimes not. So what challenges do IMGs face in US or rural West Virginia settings? The study identified that some of the main challenges retaining IMGs in underserved areas include insufficient educational opportunities for children, lack of access to arts, culture, and leisure activities, and economic and infrastructure challenges, including comparatively low wages. And we heard a lot about limited broadband access. There are also all these indirect costs that we learned about. So if these opportunities aren't available, including, being around, they wanted their children to be around people who looked like them. So they would not live in the place where they were actually working. So there would be all these costs. And sometimes, West Virginia can be, especially at certain parts of the year, difficult to travel in. So, the commute could be very costly, there could be other challenges associated with that. Study participants reported that IMGs who were unable to engage with members of their own ethnic, cultural, and religious community through religious services or community activities were less likely to remain in the area long term. So access to familiar cuisine, including ethnic restaurants and grocery stores, was also cited as a major determinant of the long-term retention of IMGs in rural areas. Perceived and actual vulnerability due to their immigration status, including within institutions, was cited as an issue. People felt like they could be or were exploited because they were dependent on the institution for their immigration status, and also incidents of bias and discrimination, which I'll describe more. The IMGs in the study reported experiencing discrimination bias from their patients and sometimes their colleagues. Patients would sometimes question their credentials and competence and ask to be treated by another American or sometimes a white physician. Some IMGs reported verbal harassment owing to their religious affiliation, particularly if their religion was outwardly apparent, such as by dress. Muslims had, it seemed to be more bias and discrimination towards Muslim in the study, and Muslims of color. The IMG sometimes reported feeling as though they were in competition with US educated physicians, both for scarce residency positions and promotions. Many felt as though their status as an IMG hindered their professional advancements, as US employers were more likely to favor US educated physicians. Some IMGs reported experiencing apparent bias at the hands of their US colleagues, such as those questioning the necessity of their religious accommodations. IMGs in this study reported feeling as though public sentiment towards immigrants, and by extension, IMGs, deteriorated due to the rhetoric espoused by former President Trump. Some also noted tensions following 9/11. So I thought I'd highlight some illustrative quotes, both around opportunities and challenges, and just noting that, again, people perceive these differently at different stages in their career and over their careers. So for the first 8 years, we lived in a really small town. So it was like socially very isolating. I had to work long hours. Once I bought the practice and we were a little bit established, that's when we thought about what we would do. And then, so what was important for us? And at that time, we started going to our local mosque, meeting people and all that. And so then the main thing we decided to stay in West Virginia was that there was a good community. And this isn't a part of the state that I doubt there was a mosque before there were enough IMGs for that to happen. It's not the capital city. I think as an IMG, and I knew I would have to work twice as hard and apply myself to be on par with my US colleagues and stuff. I have no complaints. The unique thing, or the good thing about this country, is that if you work hard, they recognize you, and you get rewarded by that. But also, I haven't seen my family for 7 years now. I'm missing a big part of my life. This is my family. You never know. Maybe my mom will get very sick and I have to take care of her. So I might be put on the option where I have to go back. So in the Trump administration and in certain forms of immigration now, or moving back and forth from countries, this is not just a perceptual issue. Going back and forth might make it very difficult to get back in the country, including to resume your position, or you would just not risk it and miss very important things in your home country. One thing that particularly bothers me is the perception that the US is doing IMGs a huge favor by accepting us here. A lot of people might feel that way. I don't feel that way. I would have been happy back home too. I would be happy to go back. Respect and being welcomed and those kinds of things matter more to me than the other luxuries the US has to offer. So no, you're not doing any favor. I am here serving you and your people as well. There have been times when I have been like, why am I working day in, day out, working so hard for people who are not even welcoming me, or at least for a country whose government isn't welcoming me? But at this point, probably because of the current political climate, I'm not inclined to stay in the US long term. So what are our obligations? And I'm about to turn this over to Elizabeth, given the essential role they play in the US healthcare system. IMGs help address physician shortages, yet our study suggests why fewer are staying long-term. Some of them want to specialize. This isn't an option in rural places. They are interested in living somewhere more welcoming to immigrants. And then there are policy barriers to staying in the US to practice. That backlog I mentioned, sometimes also there are sort of indirect policy things that you don't think about, is that their family comes over and their family's on different kinds of visa and they're in the queue for like over 10 years to get a green card, and their family's visas expire in that time. And that can be a real tricky business. Or their children age out of certain kinds of family visas at that time. IMG choices depend on factors beyond immigration benefits, as I mentioned. Recent immigration policies and rhetoric are continuing to empower patients and sometimes colleagues and community members to question the roles, in the case of patients, of members of their healthcare team, and are placing more noticeable strain on IMGs and administrators forced to respond. So I will stop there and turn it over to Elizabeth.
Thanks so much, Kata. That's fantastic. And I'll just talk for a few minutes about some of the ethical dimensions of the project, which I was involved with. But perhaps I'll just start very briefly with some comparative statistics from New Zealand. So we're also heavily reliant on foreign trained physicians and healthcare workers more generally, but 43% of physicians overall are IMGs in New Zealand, and that's up to 52% in rural areas. We train fewer medical graduates in comparable countries, and we have high rates of immigration. So this makes us quite vulnerable, particularly to acute shocks like the pandemic, but also generates persistent shortages, especially in rural areas. And in recent years, there have been more stories and reports of IMGs leaving New Zealand, having come here partly because they have trouble securing training positions, have trouble securing residency status for themselves and their families, and usually leave for countries with higher pay or better immigration processes. So we had a sort of two-part ethical analysis of the project, or an ethical framework. And the first part is about reciprocity, the second part is about harm. So in bioethics, most discussions about medical migration are dominated by concerns about brain drain. So discussion of issues of justice when people migrate from low-income settings to high-income settings. And in this context, it's pretty common to talk about reciprocity. So reciprocity is a norm, sort of good for good, give good for good received. And it's sometimes argued that as a way to stem brain drain, governments can impose conditions on medical graduates, say a condition to work in a rural area for a period of time after graduation or something like that, as a reciprocal return for the training that they've received. So we've argued that there's another side to the reciprocity coin, and I think perhaps this won't come as much of a surprise given the description of the sort of findings from Kata's study. So we started from the assumption that governments have some moral responsibility or moral obligation to secure access to healthcare services. And clearly medical graduates, IMGs and healthcare workers more broadly are a critical part of helping the government to meet that responsibility. So this raises the question of what governments owe to medical graduates in return for their contribution to helping the government meet that moral responsibility to provide healthcare. So we've argued that any reciprocity demanded of healthcare workers must be accompanied by every effort on the part of governments to secure the kinds of conditions that will allow healthcare workers to work in the system of their own accord. So those conditions include what you would expect: salary, workload, working conditions, and access to professional opportunities. But for IMGs in particular, we've argued that this includes conditions related to immigration pathways and training pathways, as being especially critical to that group of medical graduates. So to the extent that IMGs contribute directly to the government's capacity to meet its obligation to provide healthcare, the government's under a reciprocal obligation to IMGs and other medical graduates to offer secure immigration and training pathways as a key component of their working conditions. So that's the reciprocity argument. And then the second set of arguments is about harm. I think Kata's research has shown that IMGs experience a range of harms resulting from complex immigration and training policies, processes, experiences of bias and discrimination, social and cultural barriers, feelings of being undervalued, which came out particularly in the COVID responses, and in some contexts, hostile political rhetoric. So the obligations of reciprocity provide some reasons of justice for the governments to address those harms. But there's another reason to address those harms, and that stems from the government's obligation to provide healthcare, because any policies that constrain the contributions that IMGs make, and I think that's particularly clear with the immigration policy in the US, all policies that lead to brain waste, and we haven't talked about that, but brain waste is where we have underutilization of skills. These policies indirectly harm the communities that IMGs primarily serve. So other scholars have calculated that brain waste can be very costly for systems like New Zealand and the US that are heavily dependent on IMGs and other kinds of immigrant healthcare workers, because they fill many gaps in areas where health services are already under strain, and West Virginia is a perfect example of that. So we've argued that ignoring the welfare of IMGs can create and exacerbate injustices, both for themselves, but also for communities that are already struggling to access healthcare services. So I'll finish up with that, and we can turn it over for questions and discussion. For our Zoom audience members, our convention is usually to use the raise hand function on Zoom so that you can tell us that you'd like to ask a question, and then you can unmute and ask your question. And for those in the room, just a regular raise hand convention. So we'll try and alternate between the room and the Zoom. So yeah, okay, we'll start with the rooms.
I was just wondering what where you're targeting the outcomes of your project. So is it immigration policy in the different countries directly, like, so therefore targeting government, or is there a role to target the medical, like the AMA, or the I guess the medical, not quite sure, would it be the medical council that would lobby? But so I just wondered where the levers are that you want to pull.
Well, that's a great question, and Kata has translated the findings into a whole resource guide, so I'll let her talk about who that's aimed at.
Yeah, I think the first thing, I can talk about the resource guide in a minute, but just to say that part of our set of obligations in the project was to disseminate things to the immediate stakeholders, which included, in West Virginia and similar areas. So I've started speaking to, as possible, and that wasn't possible for some logistical contagion reasons for a while, to things like the American College of Physicians in West Virginia. And this, I gave a talk to a group of largely IMGs by virtue of where it was, other places like that. We're finalizing a resource guide, which is for a variety of audiences, but we really start local with IMGs, I think, and with administrators in this and similar contexts. And we want to generalize the resource guide includes our basic findings of the study. So that there can see a recognition of issues. There are a set of recommendations associated with it for administrators and healthcare institutions in these settings, which is our predominant focus, and then a variety of resources that different actors, but again, mainly IMGs and administrators can access. And these include immigration related resources, but also anti-bias trainings and things like that. As for whether or not we're going to be, our findings will be targeted as things like the AMA and other things, that isn't our primary target at this point, because we don't think necessarily we're the audience for them, but we hope that some of our published materials be read in those kind of contexts.
Thanks, Kata. Ben, go ahead.
Really interesting presentation. The train of thought I've been having recently is about the responsibility that a medical graduate has for the people who have enabled them to do their training, all the patients who've been available for them to be able to learn medicine, and for the community for whom they've paid. And yes, they do have student fees in New Zealand, but this government still provides a substantial amount into their training. And the reason you've got IMGs is because the local graduates aren't servicing the underserved areas, and that this is a better solution than the alternatives, but it's taking the focus away from, I think, the responsibilities that Western societies have to do this for themselves, and they're being solved by stealing doctors from India and the Philippines and wherever else, where it's cheaper to train. Well, why don't they pay them the amount that needs to be trained? I'm sure you get the train of thought, and I see that it's a tangent to most of what you're doing, but I wondered what you thought about that.
I don't think it's a tangent. I'll go ahead, Kata.
No, go ahead, Elizabeth, and then I'll talk.
Oh, okay. I don't think it's a tangent, Ben, but I think so I think your question is about what medical graduates owe in return for what they get in their, was a significant investment in their education and things. And so I think we've struggled a little bit to separate our work from that quite dominant framework around medical migration and brain drain, and this is part of it. And one thing we worked quite hard at was establishing this idea that that kind of reciprocity, so the reciprocal return that medical graduates owe to the country that has trained them, is really reasonable or ethically appropriate, you might say, only if that system has set up the conditions in which those graduates can, the conditions are such that they would want to work in there of their own accord. So it's that they may have some obligations of reciprocity to the countries that have trained them, and to the governments and the taxpayers and so on. But I think though that possibly shifts the burden too much onto the graduates and away from the obligations that governments have to maintain a system that pays them well enough and supports them sufficiently and so on, that they would want to stay in that country of their own, in that system of their own accord. So I sort of feel like it's perhaps just trying to move that spotlight a little bit to make sure that we're holding everyone who has an obligation to account for whether they've met that obligation, I suppose. Kata, but sorry, you wanted to add something.
And I think embedded in those points that you made was also sort of how it might draw attention away from the fractures and deficits of the healthcare systems in needing that labor. And I think I would argue that this is I share those concerns about the healthcare system, and this is an empirical description at some level of one of those consequences with all the entailments that you talk about. So I think it's just not the focus, but it's certainly part of the foundation of why we undertook this work as well.
I guess the other element which is particularly relevant in New Zealand at the moment, where we're conscious of the inequity with underserved populations such as Māori and Pacific, and that an important strategy to deal with that is by recruiting more Māori and Pacific students to work within their communities, because as a generalization, the same thing happens here, that their communities are serviced by IMGs who don't have the training at an undergraduate level in how we practice medicine in New Zealand, and in particular about the cultural expectations of good practice of medicine amongst some of the minority communities. And so one of the problems that I think that's exacerbating some of those inequities is a sort of colourblind view to medicine, that you learn medicine and medicine is the same the world over, and if you've learned it in India, it applies in New Zealand, and that has resulted in our inequities in our health system.
Yeah, and I think that this is another entailment of this is questions about how we train in the United States persons who understand the particular complexities and often come from rural areas, and then how do we retain them, you know, and that there have been various efforts in different kinds, and some of them address things like the medical school debt, the underlying debt, but as you say, it's a much more complex issue around culture and choice and freedom of choice, and how medicine is very different in these contexts in meaningful ways.
Thanks, Kata. Any other questions?
If I may just add to,
Yes.
If I may just add to what Ben said, there's a pilot that's being run this year for international medical graduates, and it's been run in New Zealand for international medical graduates who pass the necessary exams to become registered here. And I think that's one of the things they're looking at, the point you raised about how Māori and Pacific health issues is being covered in some of the modules that they're going to be exposed to this year. It's a rather small pilot, I can't remember the number of students, that the number of doctors who are taking on board now, I think maybe something like 10. But I did also have one question. I was wondering, in looking at the international medical graduates here in New Zealand, did you make a distinction between, so on the Medical Council website, they have a list of about 30, 40 countries of comparable healthcare systems. Do you make a distinction between those doctors who can pretty much walk in, you know, to the medical system, start practicing after they sign off on a few documents, versus other international medical graduates from the Philippines or from India or from other developing countries who have to sit several exams, range which will probably take the cost up to somewhere around $8,000, I think last time I checked, and then have to wait in limbo for close to about 5 years. And I think the last I saw earlier this year was there's about 100 of them waiting, and about 50 of them have been waiting 3 or more years to get a first-year position as a trainee doctor. Did you make a distinction between these two groups?
So yes, that's a very important distinction, and I think the group of graduates that you're talking about that experience those barriers and delays are more closely related to IMGs in the US who sort of start from zero, regardless of where they come from. They have to go into a residency program and do their entire residency, regardless of their medical background. So I think that's an absolutely critical distinction. And when we talked about brain waste, and concerns that have been raised around brain waste and the implications of that for the New Zealand healthcare sector, that's the population that's really being discussed, because they're languishing in various ways at different points in that system. Yeah, so I think it's a really important distinction. Yeah.
Masha had a comment.
Oh, Masha, oh, sorry, thanks. I'll just look this up in the chat. Okay. As an overseas trained allied health professional, I have often struggled with feeling guilt that I was using my education, of which a large part was paid for by my government, as was the norm for everyone at that time, overseas. Yet the work I do is very much underfunded. So there was no work, and for me to get work experience, I had to look across borders. I enjoyed my move abroad and jumped through all the hoops to stay. Thanks, Masha, for sharing that comment. And Kata, I'm sure that sounds quite similar to some of the
Yeah,
data from the study.
right. Again, it's, you can conceptualize it in terms of push-pull, people coming from underfunded systems or with enormous patient loads. And also just to acknowledge that while our study didn't focus on it, and in the United States, it's not only physicians that are essential in terms of immigrant healthcare workers there as well. So that's something that perhaps I'd like to explore in later research as well, that role and the maybe different and overlapping challenges and opportunities there.
Thanks, Kata. I think that's definitely clear in the New Zealand context too, where it's not just foreign trained physicians, but nurses and other health professionals as well. So we're just about at time. If anyone has a burning final question, we could perhaps take one more. But otherwise, it just has been a great pleasure to have you, Kata. I want to thank you very much for giving up your Sunday evening to be with us this afternoon. And not to move on too quickly, but just to use this as an opportunity to advertise our next week's seminar, which is being presented by Dr. Katrine de Volder from Oxford University, and she's going to be here in person. She is asking the question, is Stephen Fry lazy? And possibly answering this question as well. So thank you all for coming, and thanks to our Zoom audience, and thanks again to Kata. Great. There's some messages on the chat there, Kata. If you want to wait. Oh, I think he was clipping. Great.
Thank you.
Thanks very much. Thank you. Thanks for coming. Bye. See you later. Thanks, Kata.
You're welcome.
That was great. It's so nice to hear the whole I'll stop recording. It's so nice to hear the whole